doctors need to understand that these are guidelines. They should have the flexibility to have some leeway in making the diagnosis of EDS.
Welcome back, every Bendy Body, to the Bendy Bodies Podcast with your host and founder, Dr. Linda Bluestein, the Hypermobility MD. My guest, Dr. Pradeep Chopra, and I are tackling some of your hardest questions today. For example, how does Ehlers-Danlos syndromes present differently in different sexes? Are hypermobile EDS and HSD actually different conditions? And are the hypermobile EDS criteria appropriate? And so much more. But let me first introduce Dr. Chopra to the few people who do not yet know who he is. Dr. Chopra is my friend, mentor, and the one who convinced me to open an EDS medical practice in the first place. He is world-renowned for his incredible work in EDS and HSD, POTS, MCAS, CRPS, and central sensitization disorders. Dr. Chopra is a Harvard-trained, board-certified pain medicine specialist with over 25 years of experience. Jennifer Milner and I interviewed Dr. Chopra for episodes 70 through 73, which covered the impacts of EDS in a head-to-toe fashion. Dr. Chopra has since joined me as a guest co-host for episode 77 with world-renowned neurosurgeon Dr. Paulo Bolognese and episode 152 with Dr. Theo Herides. I'm so excited because these are your really important questions and we're here to address them for you. Please submit your questions to bendybodiespodcast.com and subscribe to the Bendy Bulletin at hypermobilitymd.substack.com. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. Stick around until the very end so you don't miss any of our special hypermobility hacks. Here we go. So I am here with Dr. Chopra, and I'm so excited to get to chat with you today.
Oh, my pleasure. I love being on Bendy Bodies. And thank you for inviting me again, Dr. Bluestein. Not sure why you keep inviting me, but thanks for inviting me.
Of course, I keep inviting you. Everybody loves hearing from you. And I wanted to share because when I was talking to Tessa before we started the recording, she was like, I didn't even know that you two knew each other outside of Bendy Bodies. And I was like, so we have to tell that origination story. I feel like it would be, really helpful. I want people to know how much you helped me. When I first wrote my first article about pain and hypermobility disorders in 2017. And of course, I was doing my literature search and everything, and I came across the article that you had written for the big journal, the big genetics journal, and you were the lead author. And so I sent you an email and I said, here's a draft of my article. What do you think? And you were so kind to write back. So we started having some, email conversations, which then led to a phone conversation. And I think that first time we maybe talked for a few hours. Does that sound right to you?
Yes. All our conversations wind up being a few hours. I've been teaching medicine for many, many, many years. And I can differentiate between a good student and a not so good student. Because with a good student, every teacher wants to put that extra effort. And, with not so good students, we like, why waste time? And one of the things I liked about you was that you're very inquisitive. Actually, you still are. I still get this occasional email. I remember you sending me an email on LDN, and you're constantly learning and evolving. And I don't know, I think it was 2017 when I first met you, and then we bumped into conferences, and I was so impressed with your enthusiasm to learn.
Oh.
It was amazing. And then you also went on a slightly different track with helping dancers and all. And I was like, I was proud of you. And this is one of the things that teachers like, is to see an enthusiastic student. So it was a pleasure teaching you because I knew you would do well with helping other people.
Oh, I really appreciate that. And you were so generous with your time. And I felt like I kind of followed you around to these different conferences that you were speaking at and then would pick your brain. And I don't know how well you remember this conversation. And I'm curious if you remember it like I remember it. It would have been in the fall of 2017. and we were having a conversation about, whether or not I was going to open a practice. And you kept telling me, I think you need to do it. I think you need
Yes.
to do it. Yeah. And then you were telling me
Yes.
you're ready. And I felt like it was, before you have children, you're like, I'm not ready. I'm not ready. Uh,
Yes. I remember that conversation because one of my things is that I want more people out there uh, treating EDS, or rather EDS specialists.
mhm.
And, it's because the more people there are, obviously more people get help. And one of the things about you was that uh, you were in the Midwest, you were in Wisconsin. And I said, listen, you're the best person to do it. You know EDS better than most people do because you live it. And and we were at that point in 2017, we were desperate for more people out there. Now we have some more people, but we really need a lot of people to understand this whole complexity of EDS, mast cell, parts, and all that goes along with it. So you were ready then.
Yeah, yeah. You said you're ready, and I was like, okay, well, I guess it's one of those things where you just have to jump in with both feet. But anyway, I was so excited to tell that story because I think a lot of people may not realize that we've met in person multiple times, and I wanted everyone to know how much you helped me, and I'm forever grateful. And yes, I do still send you emails from time to time to pick your brain on different various topics. And of course, you've been on Bendy Bodies quite a few times now, both as a guest and as a guest co-host. And I've enjoyed every single one of those conversations, and can't wait to see where this leads. So it's who knows what we're going to end up talking about. I'm sure it's going to be fun for everybody.
This is going to be an interesting episode because there are a few things that I like to discuss, uh, which which I think are burning topics in EDS.
Okay. Do you want to start with your burning topics? Because we absolutely can.
No, you were the one who sent me that question.
Okay. Okay. We'll start with some of my burning questions, and then we can move on to some of your burning questions. Okay. Sound like a plan?
Okay.
So the first question comes from one of our followers who asked, "Why is the hypermobile EDS diagnostic criteria the same for males and females when boys often present differently and tend to score lower on the Beighton score? My brother only scores a 3 or 4, so doctors hesitate to diagnose him even though he has frequent dislocations, marfanoid features, gastrointestinal issues, migraines that cause him to vomit, chronic pain, and fatigue. It's frustrating to see how many men and boys are dismissed because they don't meet one specific metric." And I wanted to talk about this too because I do get messages from men, boys, males who feel like they are ignored because obviously we see so many more females than males, right? So I thought it would be important to talk about how this does present differently in men and boys, or what you're seeing in your clinical practice, and should we have different criteria for the different sexes?
Yes. Uh, so the 2017 hypermobile EDS criteria, diagnostic criteria, has a lot of flaws. A lot. Um, and uh, a lot of doctors who have not adapted to it, and they don't accept it. And oftentimes, when patients come in, this is the first question I ask: who diagnosed you with EDS, and did they use the 2017 criteria? I use it because it's a standardized criteria. So I don't want anyone else coming back and saying, "Hey, you didn't use the 2017 diagnostic criteria." Uh, but there are many, many flaws in it. And this is one of the biggest flaws, is that it does not differentiate between men and, well, males and females. It's also skewed towards adult females and not as much for younger girls.
Mm,
And we'll get to that later on.
mhm,
Um, so, males, it is well known that the Beighton score, which the 2017 criteria depends on so heavily, and most doctors do depend on so heavily, uh, is it evaluates a generalized joint hypermobility, but it has been shown that males score lower than females on average in on the Beighton score itself. Just by of the three components on the Beighton score, males score lower compared to females in general.
Right.
And that, there are reasons for that. And we, the muscle structure in boys is a little more tougher than in girls. They don't go through the hormonal changes that girls go through. But so the criteria in the total EDS criteria, the 2017 criteria, they have differentiated by age groups, but they never differentiated by male and females.
Right.
And so right off the bat, the Beighton score doesn't apply. It's not fair to males. It's not fair to boys. And again, joint hypermobility naturally decreases with age. But in boys, it actually decreases more as they enter into adolescence and adulthood. Joint hypermobility decreases in boys. And then there are other things like ethnic backgrounds, muscle bulk, athletic conditioning can also reduce joint hypermobility, obscuring the actual underlying pathology. And so the Beighton cutoff for boys and girls should be different. And I'll come to a solution at the end of all this, but first I need to just clarify that I don't want people to worry that, okay, doctors have to understand that they have to, we're not all Toyota Corollas. That I can, in a Toyota Corolla, I can a mechanic can put a hand close his eyes and put a hand in there and touch a nut and say exactly what that nut is, what that nut does. We're all different in many ways, many, many, many ways. And this is one of the ways. And, what's disappointing is that this 2017 criteria was established in about 8 years ago, and no effort has been made to fix it. That's the problem. It was hoped that, in all conditions, in every disease, and I can take one, for example, CRPS, complex regional pain syndrome, which is an extremely painful condition. They came out with the criteria, a while back, and it was called the Budapest criteria. I think it's about 20, 30 years old. So a bunch of people got together and they went to Budapest, they came up with the criteria, but a criteria is not established and is not accepted unless you prove that it is correct. So they eventually did studies on it. And a few years later, they produced another paper, the same group. And they said, yes, we were right. The criteria that we put out when we met in Budapest is valid. Not only that, they met again recently, a couple of years ago in Spain, and it's called the Valencia Consensus. And in that, they again said, yes, it is still true, the Budapest criteria, with a few tweaks. They clarified a few things that were causing confusion, but they said that it's still valid. And that's how it should be. Unfortunately, with this 2017 criteria, 8 years later, we are still where we started with. So yes, sex does make a difference. Boys tend to have lower Beighton scores, and that has been shown again and again.
So, totally agree with you about the difficulties with the 2017 criteria, starting with the Beighton score, and then there's like the little side note about the 5-point questionnaire, which I think is a great tool, by the way. And the 5-point questionnaire, of course, is really important for historical joint hypermobility. So we have the same problem as you were pointing out in older people because their joint hypermobility is going to go down with age. So they might score low on the Beighton score, but they still meet all the other criteria. I had a patient recently who had a Beighton score of 1 out of 9, yet she had 6 of the 12 criteria in the middle. And I do use the 2017 criteria also. And it's important to note that for these two examples that we're talking about, for both hypermobile EDS and CRPS, the challenge is because these don't have a really good, reliable biomarker, or in the case of hypermobile EDS, no biomarker. So we're using clinical criteria, right? So that's the
Right.
challenge, and so getting a group together to decide on clinical criteria is challenging enough. But you raise an excellent point that it should then be studied. Are those clinical criteria, do they seem to be appropriate or not? And in the case of, for example, CRPS, do you know what the time frame was? Like, you're pointing out that the Budapest criteria came out, quite a long time ago. Do you know, like in that 8-year time span, if it would be, normal that there would be a number of studies conducted? Because I know that there is the project, the Road to 2026, where, they're looking at revising the 2017 criteria, and they did publish in 2023 an update for pediatric patients to the 2017 criteria. But yeah, we know there's a lot more work that needs to be done.
The update, so on the CRPS criteria, they sort of clarifying the Budapest criteria. I think it was only a few years.
Mm.
I think it was about 4 or 5 years. And that's the average time it takes to do a randomized control study.
Mm-hmm.
And they did this study, and within a few years, they came out and they said, yeah, it does meet the criteria, and then reconfirmed it a couple of years ago.
Mm-hmm.
And that's done with almost all conditions where they have said that, hey, uh, let's say pick up rheumatoid arthritis, rheumatoid arthritis, this is what we think is the diagnostic criteria for rheumatoid arthritis. But just because we said it doesn't mean that it's written in stone.
Right.
So we got to do studies to prove that this criteria does match up, or add it, or a tweak it,
Mm-hmm.
add or take away things. And that's how it. So we're hoping that the 2026 may have additional information. I don't have any information on that yet. So hopefully we'll have something there. Uh, One of the things about, so the question that you had asked was that, his brother scores very low on the Biden score.
Mm-hmm.
He gets only 3 or 4. And so the doctors don't want to diagnose him with hypermobile EDS. But they also have to remember that the 2017 criteria does not weigh heavily on the Biden score. Uh, Doctors have to look at these patients and say, okay, do you have all the other features? And like this, his brother has frequent dislocations, paraphernalia features, GI issues, migraines, chronic pain, fatigue, which are all what you find in patients with hypermobile EDS. So you take that into consideration. Okay, this is a male, his Biden score is likely to be low, but has a lot of the other features. Which, again, going back to my Toyota Corolla analogy, just because you don't have that little sticker saying on the back Corolla doesn't mean that it's not a Corolla. It has all the features of a Corolla, so it must be a Corolla. And that's where clinical science and medicine comes into place, to look at the whole patient and understand. Okay, these are guidelines. They're not written in stone that you have to. It's not the law. These are to guide patients understand, and that's why they're called guidelines. But you have that flexibility to understand. Yeah, if there's something else that explains this condition, the symptoms that he has, sure, go ahead with it. But if you don't have any other diagnosis, you can't. It's unfair to send this patient home saying, "Well, you scored only 3 out of 10 on the 9 or the Biden score. Therefore, you don't meet the criteria. I don't know what's going on with you." That would be very unfair.
Mm-hmm.
So you got to look at the patient as a whole. That's the important part.
Yeah. No, I totally agree about looking at the patient as a whole. And I think another frustration that a lot of patients have, totally understandably, is that the comorbidities are not part of the 2017 criteria. Now, they are kind of part of the 2023 criteria for, pediatric patients. There's like these 5 questions that you ask. Is generalized joint hypermobility present? Musculoskeletal complications? Are there comorbidities? Skin and tissue involvement, and then have other conditions been ruled out? So for that 2023 pediatric criteria, they do ask about comorbidities, but for the 2017 criteria, comorbidities are not included. So if you have POTS, if you have mast cell activation syndrome, like if you're following the 2017 criteria, that doesn't give you extra points, if you will, correct?
Correct.
Yeah.
And so, again, going back to the 2017 criteria, uh, and this happened with me recently. One of the criteria that they have in the 2017 criteria is recurrent joint dislocations.
Mm-hmm.
But it says nothing about subluxations. And recently, I came across a patient. I saw a patient with EDS. Everything was there. Uh, Went and saw a neurologist who actually was one of the authors of the 2017 criteria.
Mm.
And he said, "Well, you don't have EDS because you don't have recurrent dislocations. You have
Oh,
subluxations."
oh my gosh, you're kidding.
And I was horrified because dislocations, in the United States, we call them dislocations, but they're actually luxations. So you
Mm.
have luxations where the joint dislocates. That's called luxations. And if it dislocates and it comes back in place, or what I call as a slippery joint, that's a
Mm-hmm.
subluxation. What's the difference? The patient is still suffering. He's
Right.
still dislocating the joint. Even if he dislocates it for 2 seconds or 2 hours, he's dislocating they're dislocating their joints. And he kind of that was like his big deal thing that, it's Dr. Chopra did not documented subluxations, but did not document dislocations. And honestly, most patients with EDS don't have dislocations. They have subluxations.
Mm-hmm. Right. Well, and isn't it true that you can't tell the difference unless you have an X-ray? I mean, can you tell that you can
Yeah,
tell if you totally dislocated a joint and it's like out, and you have to go to the hospital and have them put it back in. But otherwise, isn't it true, especially if a joint dislocates and then comes back spontaneously on a regular basis? I like the idea. I love what you just said about the luxations rather than making this like maybe artificial distinction between the two, because most of the time you don't have an X-ray, right? Looking at that,
correct.
yeah.
You're right. You're absolutely right. So, so this, so in case of boys, we can't leave the boys alone. The other thing in boys is that their presentation is, like I said, is their basic structure is different. Their muscle structure is tougher, and their ligaments are a little tougher. It's just by nature of their DNA. They have this phenotype where their muscles are more, how do I put it, coarse,
Hmm.
and they are not as soft and flexible. And so their hypermobility would be very different criteria. But then you look at other things. You know, a lot of the patients that I see that come in with hypermobile EDS, a lot of a majority of their problem is not the EDS portion of it. It's either the POTS part of it, or the mast cell part of it, or the CCI part of it. And so I tell them that. I said, listen, don't worry. We're here to fix whatever is broken. And whether it's EDS or whether you call it EDS, a zebra or a giraffe, it's irrelevant. You're suffering, your quality of
Hmm.
life is not good. Otherwise you would be coming in my office seeing me.
Right.
You would be out there, in school or something, studying or having fun. And so whatever it is that is stopping you from functioning, that's our job to fix.
Hmm.
And that what I want to talk to you about was what makes you, Dr. Bluestein, special in treating EDS. So I was asked this question. That's why I've been asked this question many times. Like, hey, you are an anesthesiologist. How come you're treating all these things? You're not a you're not a cardiologist. You're not a immunologist, or you're not a orthopedic surgeon. How come you can treat all this? And that's when I realized that our education is purely based on studying each and every one of these conditions. Anesthesiologists have to know cardiology. They have to know, pulmonology, GI, and cardiac stuff and everything. Not only that, as an anesthesiologist, you can have a patient with a heart disease come in for an appendix. And now you've got to match both of them. So the patient might be
Mhm.
septic and has a heart disease. It doesn't get more complex than that. And we handle those. So we know our anatomy, we know our physiology, we know our medicine. And this is the only branch in medicine that has to be an expert at all these branches.
Mm. Yeah, good point.
See, you didn't even know how awesome you are. So
Well,
you got to change your sign plate outside. Specialist, and then you go down anesthesia, ophthalmology, cardiology, put all of those down there.
yeah, no, those are good points because our training is very different than what I think most people realize. I don't think most people realize that, like you said, we have to know about all of those things because we have to know how they impact, the drugs that we're going to give and the positioning that we're going to be doing and all of the other aspects of their care. So, and I forgot to mention the article that you and I wrote, which was also fun.
Yes,
Yes.
the
Yeah.
article that Dr. Bluestein is talking about perioperative care and anesthesia. And we talked about what are the precautions you have to take for a patient going into a surgery, what anesthesiologists need to know. And uh, since you touched that subject, I need to bring uh, one PSA. And the PSA is that one of the things that I've been seeing is that patients who are going in for uh, tooth surgery, like uh, wisdom tooth extraction or nose surgery or even general anesthesia, even though they tell the anesthesiologist that I have EDS, they still hyperextend their neck. And then they end
Mhm.
up with CCI.
Mhm. Yeah.
And that has me really worried. And so I did write to Dr. Bolognese, who's the neurosurgeon, and I said, are you seeing this? And he said, we see this all the time.
Mm.
So we're in the process of writing up a case report of 8 patients that we saw who had some sort of a facial surgery or dental extraction, ended up with CCI.
Mm.
And we had written this in our paper back when we published it in the perioperative care for patients with EDS undergoing anesthesia. We had mentioned this carefully, like you got to keep the head neutral, you've got to do fiber optic intubation. We said that. But in most, but in a dental office, they don't pay attention to these things.
Well, I would say probably in a dental office and unfortunately in other practices. I know I don't know about you, but I write a lot of letters for patients and clients if they're going to be having surgery. And fortunately, it seems like a lot of the time they are well received. But if somebody doesn't have something like that and they just say, oh, I have EDS, so please be extra careful with my neck, I feel like that's often not taken seriously. And speaking of the paper that we published, and I believe it was published in 2020, 2019 or 2020, something like that, and we'll link that in the show notes, of course. But I remember when we first started writing that, I had this, idealistic. I'm thinking, oh my gosh, this is going to be in the New England Journal. This is going to be, in JAMA. This is like so. I know. This is how naive I was. I'm thinking because I'm thinking to myself, everyone needs to know this. And I had been going to anesthesia conferences for, a couple of decades. And I knew that there were all kinds of lectures on positioning, but I never heard any mention of connective tissue disorders. So I'm thinking to myself, every single anesthesiologist needs to understand the implications of positioning a patient under anesthesia or managing their airway, like you said, extending the neck, etc. And so I'm thinking this is going to just be like this is going to be big, right? And then you were submitting it to all these different journals, and you had to keep telling me, we got to keep trying, we got to keep trying, and I was shocked because tell me again what the response was that you were getting when you.
So there was one response that was just mind blowing. So there's a very famous journal called Anesthesiology.
Mhm.
It's like the Bible of
Right.
anesthesia. Everybody reads it. And I wrote to the editor and I said, listen, I have this article that we've written on, EDS and patients going through surgery with EDS. And the response was, oh, we don't our readers don't get that many patients with EDS.
Oh,
If you want to write an article on pain in EDS, sure, go ahead. But our anesthesiologists don't see many patients with EDS. And I'm like, first, number one, you're wrong right there.
right,
Okay.
right,
Because EDS patients do go through a lot of surgeries.
right,
The second thing is that, okay, so they don't see many EDS, but do they see at least 100? So you mean
right,
you can go ahead and damage their necks in
right,
these 400 patients that you've just seen
right,
instead of warning them about it?
right.
And and a few years later, after we had written that article and it was published, I did write to him a follow-up and I told him, look, we have a case series of 8 patients that which you thought was not relevant for your journal has turned out to be extremely relevant.
Mm.
One patient had actually developed paraplegia from
Oh,
that.
no.
That was what motivated me to write to him.
Mm-hmm.
So on that question, for the dentists, what I tell patients now is that even though I write it in my notes, I don't think they read my notes. Uh, the dentists don't read my notes,
Right,
uh, mainly because my notes are 17 pages long.
right,
And
right, right. Mine too.
but so, but what I do tell them, I tell patients is take your neck collar with you.
Mm.
If you don't have one, buy a neck collar, a hard
Mm.
neck brace, and put it on
Yeah, great idea.
because now they won't forget. And even
Right.
if they try to hyperextend your neck, they can't because you're in the optimal position.
Mm-hmm.
And that's what I tell them. I said, don't try explaining to them. They won't remember. They get busy with their digging around for that third molar, which is back in there. The wisdom tooth is right back in there. And so put your collar on. As it is, the
That's
numbing medicine doesn't work. So now you're
right.
screaming because the lidocaine didn't work. And you're like, that hurts. And then the dentist is getting frustrated because he can't get in there because you're screaming in pain. And so he takes your neck right way back, opens your mouth big, and then you end up with CCI.
Yeah. Yeah, that's a great suggestion because you're right. It doesn't matter if we try to make it short. There's going to be
So that's
people
a
that are
hack,
going to.
by the way.
Yeah. Yes, that's a
We
great hack.
snuck in a hack.
Yes, yes, I love
So
it.
hack is always carry your neck brace. If you're ever getting anesthesia, dental work, doesn't matter how small it is, or anything with the nose. One of the cases in
Right.
those 8 cases is a patient who had turbinate surgery, nose surgery.
Yeah, because for
And
nose surgery, also you're positioned like that. Yeah,
yeah,
or thyroid or parathyroid, right?
that's right.
Yeah,
Yeah, that's a good
yeah.
one. So
So okay,
we got to hack right in the first half hour of our,
love it, love it.
there you go. Neck brace for
Perfect.
everyone. So if
Yeah.
you're wondering which neck brace, it's the Miami J collar would be the best one. It works otherwise also. And if you want to take it to the dentist or wherever, take it with you. Even if you're going for surgery, if it's a major surgery, tell them that you need to put the brace on.
Hmm.
Insist on that when you have your pre-op testing.
Yeah, I think
And
that's a
if you get a
great hack.
and yeah, and if they get a pushback, if you get a pushback saying, "Oh, but you don't have instability," tell them that I don't want instability. That's the reason why I'm wearing this brace.
Mm-hmm. Mm-hmm.
There are too many cases. And I talked to Dr. Bolognese about this. I said, like, how many are you saying? He says, a lot.
Mm.
So I was kind of horrified with that. All right, we just cured CCI.
Yeah, and
Look at that.
and yeah, and like you said, I mean, even one case is too many. And I'm glad you pointed out
Yeah.
about the journal Anesthesiology because yeah, that's what everyone reads. That's the journal. So we're going to take a quick break, and when we come back, I want to talk a little bit more about this hack because I think this is really important, and I have a follow-up question related to that. But we're going to take a quick break, and we will talk about that a little more when we come back. This episode of the Bendy Bodies Podcast is brought to you by EDS Guardians, paying it forward in the Ehlers-Danlos Syndrome's community, patient to patient for the common good. I am proud to serve on the inaugural board of directors for EDS Guardians, a small charity with a big mission and a big heart. Now seeking donors, volunteers, and partners. Patient advocacy and support programs available now. Travel grants launching in 2025. Learn more, shop for a cause at their swag store, and join the revolution at edsguardians.org. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube, and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. Okay, we're back with Dr. Chopra, and we were just talking about this paper that we published in late 2019, early 2020, something like that. And it was about perioperative considerations in people with EDS, and how I was thinking this was going to be in some massive journal. And we got it published, and it was great. But I definitely did not have my finger on the pulse on that one. And you were giving us this great hack about wearing a neck collar. And what I wanted to ask is, do you think that anyone who has an EDS diagnosis should do that? And then my follow-up question to that is, what if you don't have an EDS diagnosis, but you have an HSD diagnosis, but you don't have any known neck problems? Do you still do it?
All right, let's talk about that. Okay. If you have an EDS diagnosis, buy a neck collar, whether you have CCI or you don't have CCI. Because if you don't have CCI, you don't want CCI.
Mm-hmm.
So it's like a airbag. You pay for an airbag in the car, whether you want it or not, whether you probably hopefully never use it. So the same thing, if you're getting any kind of anesthesia, any kind of nose surgery, eye surgery, anything to do with above your neck to your head, including what I call as both payments for dentists, is taking out the wisdom teeth. I don't know why they take out the wisdom teeth in everybody. Every patient that I've asked, why did they take out your wisdom teeth? And they're like, I don't know. And so I think they do it for both payments. And so it's like a safety belt. Get a neck collar. It's not worth it, because trust me, it's not worth getting CCI.
Mm-hmm. Mm-hmm.
You don't want the surgeon and his knife and with his screws and bolts in there.
No.
What was your second? Oh, HSD and yeah, that's the one I want to talk about. The HSD and the whole thing about HSD and the. Okay, I'm just going to hold off on the swear words. But can you use swear words on this? Is the FAA going to get after us?
No, I think you can use swear words.
No,
we can always beep them out if we have to.
No, I don't swear. I'm sorry. But for all practical purposes, we'll get into this discussion of hEDS and HSD later on. But for practical purposes, if you've ever been diagnosed with HSD, assume that you have to do the same precautions as EDS.
Mm-hmm.
Assume the same thing. Because it's not worth the risk.
Right.
It's really not worth the risk. If you think you have hypermobility but have never been diagnosed with it, and your entire family for generations have got all the EDS stuff, and you're the only one who has not been diagnosed, but you feel like you can do all those funny tricks, wear the collar.
Mm-hmm.
You can't go wrong with that.
Yeah, there's probably no downside really to doing that, and especially nowadays with the glide scope and other methods of video laryngoscopy, there's more options. You don't have to do an awake fiber optic intubations like that was the only option a number of years ago. So I think that's really good advice. And I do want to talk in a little bit about hypermobile EDS and HSD, and are we drawing a line in the sand artificially? Do we think that they actually are separate conditions, or do we think that they're actually one and the same? But I first want to ask you what you think about we talked a little bit about the 2017 hypermobile EDS criteria. What do you think if you could wave a magic wand and you could just pick the clinical criteria for hypermobile EDS? what would you include and what would you drop off, or how would you change it?
So do you want me to look through the 2017 criteria and let's talk about, we're going to do it together, okay? What
Okay.
should be there and what shouldn't be there, okay? Um, so so they've divided it into three criteria to it, right?
Right.
The first one is the standard Beighton score. And, the Beighton score has been around for ages and it has been well studied and everybody knows it. And it's fine to have it in there. I think it's pretty good. Uh, some people have complained that it only looks at the small joints, doesn't look at the big joints, etc. But it is what it is. We don't have a better method of doing it clinically. There are 9 things you do. Takes 9 seconds to do them. It's a quick
Yeah, it's
one.
very, very quick. What
Yeah,
have you used the lower limb assessment score ever? Because that's 12 different tests that you can do on each side. Now, mostly I see physical therapists doing this, but for a population like dancers and other athletes who tend to get injured in the lower extremities, I think that that's also a good scoring tool. And then there's the Tokyo, and I mean, there's like a million different scoring systems, right? But the Byton is, like you said, it's so quick and easy to do. It's easy to memorize, and it has been studied a lot. Yeah.
yeah. If somebody were to ask me, like, what would you add into the Biden score, I would say knees as one of the things. So make it a round figure and make it 10 things, and look at the knee. If there's hyperextension of the knees in there, so good. Yeah,
Well,
I
hyperextension
agree
of the
with that.
knees is in the Byton score.
Oh, I'm sorry. It is. Sorry,
Yeah. Yeah. I
it
I
is.
think I think if we were to add something, what do you think about adding the shoulders?
Oh, yeah.
I think shoulders
So,
would be a good thing to add.
so on the upper extremities, we have the pinky finger and we have the thumb,
Mhm.
and then we have the elbow, and then you can add the shoulder in there. And in the lower extremity, the hip is a difficult one to look for hyperextension.
Mhm.
It's difficult. So the knee is fine. And of course, the back, they've looked at the spine, which is fine.
Maybe ankles.
Actually, ankle hypermobility is probably the most common hypermobility you ever see, and also the most harmful.
Mhm.
So, yes, ankles would be a good one to look at.
Okay.
But here's the thing, going back to our male female thing, you know, if you find that, okay, this boy seems to have hypermobile EDS but doesn't quite meet the Biden criteria, then add some of these things like the ankles, or look at, like you said, look at the shoulder. Uh, because these are guidelines, as I keep saying. They're not, it's not the law. These
Mhm.
are guidelines.
Mhm.
Um, the problem is that in criteria 2, where they've asked about some of the things, I'm just going to skip some of the one that is very uh, aligned towards women, older women. So they have pelvic floor rectal or uterine prolapse in children. I don't know about you, but I've never seen a rectal prolapse or a uterine prolapse in a child.
No, never in a
I've
child.
never seen that or heard of it
Nulliparous woman.
even.
Yeah,
I've never
but
seen a uterine prolapse in men. And if I do, I will let you know. Um, for that matter, I've never seen a prolapse, even a rectal prolapse in men.
Mm, interesting.
I haven't.
I haven't either.
Hemorrhoids, yes. Hemorrhoids,
Mhm.
yes. But that hemorrhoids is common. You can't base your
Right,
diagnosis of EDS on that.
right. Yeah, definitely not.
And nulliparous women, that's women that have never been pregnant, having uterine prolapse. So now you're going into a older age group.
Mhm.
So you don't see uterine. I mean, the realistic thing is that you and I see lots of EDS patients, lots, and we have never seen rectal prolapse or uterine prolapse in children.
Right.
But are there people who are seeing them? I don't know. Why would they put them in the guidelines then?
Mhm.
And
Yeah.
so this is skewed more towards older women than younger women. And then nulliparous woman, that is really put boxing it into a very small set of women who have never been
Right.
pregnant and are having a rectal prolapse. So that criteria is kind of strange, weird. But I'm I don't know. There must have been studies that they've looked at and they put it in there. But I'm hoping in the new guidelines they'll take that off or
Mhm.
modify it.
Or modify it, right? Because what if you've had pregnancies, but you have horrible, I mean, there's also degrees of prolapse too, right? I mean, so you could
Right.
have mild prolapse is gonna be different than severe prolapse, and I think that's the other problem with a lot of these criteria. So if we even look at the first one, unusually soft or velvety skin. That's so subjective, I feel like.
Very
So that's
subjective.
yeah, that's the other challenging thing. Yeah.
Very subjective. For some reason, I mean, African American women have generally very soft, velvety skin.
Mhm,
And that's just my observation.
mhm.
Even without EDS, they have soft, velvety skin. So hard to say that. But it's only one of the five, which is okay. It's not a bad one. But this pelvic floor, rectal or uterine prolapse is really, uh, and in nulliparous women, that means women who have never been pregnant. I mean, I would change the criteria to say after, say, one or two pregnancies.
Mm,
And if you see rectal prolapse or uterine prolapse, then it's a big deal thing.
mhm.
Dental crowding is fine, arachnoidically, the rest is fine. In feature B, they've talked about positive family history. This is going to take years to happen because we have this criteria was established in 2017, and it took a couple of years for it to be accepted by people to start using it. Personally, I think I started using it in 2019 when I was a little more comfortable with it. Uh, But if somebody comes and says my grandmother was hypermobile, but she was probably they never ran the 2017 criteria on her.
Right, right.
So this
Yeah.
feature B doesn't have, yeah, a positive family history of joint hypermobility, first degree relative, then that makes sense.
Mhm,
Doesn't have to be hEDS.
mhm.
And then in feature C, they talked about, recurrent joint dislocations. Is recurrent joint dislocations another way of saying subluxations?
Well, it does say recurrent joint dislocations or frank joint instability in the absence of trauma, and it does say for feature C, must have at least one. And I don't know about you, but like all of my patients meet the middle one, the chronic widespread pain for more than equal to or more than 3 months. And then the first one, musculoskeletal pain in two or more limbs, recurring daily for at least 3 months. And I think I should also point out that you and I, so I just want to point out that you and I have been, you especially, have been seeing these patients. You were seeing these patients long before this criteria came out, right? So
Right.
for it's kind of funny. You and I are both like I'm looking at the criteria right now on my computer. I have it pulled up here, and we're having this conversation as two people who specialize in this space and there's a lot to talk about on each of these individual things. So how can we possibly expect a family practice doctor in Timbuktu to look at this sheet and be able to make a diagnosis reliably? I just have to chuckle at that because it's a lot. It's a lot for somebody to try to take in and understand, even if they have the desire to help these patients and evaluate them for hypermobile EDS.
Exactly. So my, um, I mean, these criteria are so restrictive. It has to be a little looser in making these diagnoses. And also, this these are the doctors need to understand that these are guidelines.
Mhm.
They should have the flexibility to, you know, have some leeway in making the diagnosis of EDS. And in feature C, I actually see all three of them.
Mhm.
Not so much as dislocations. I don't see dislocations. I see subluxations, which can
Mhm.
be frank joint instability. But like I said, one of the authors on the same 2017 criteria had an objection to that.
Mhm.
And I didn't realize it. And I went back and I looked at the criteria and I said, oh, yeah, they don't have subluxations in there. They only have dislocations.
Mm-hmm.
And his objection was that this patient did not have dislocations. He had only had subluxations, therefore did not meet the criteria.
Yeah, so they thought that they should not have the diagnosis of hypermobile EDS because they did not have actual dislocations, which, again, if you look at it, it does say or frank joint instability. So I also, your point about guidelines, we have guidelines all over the place in medicine, right? We have tons and tons of guidelines. But I was also curious, now that you pointed that out, I was curious to look at the very top, and it says diagnostic criteria for hypermobile EDS. And it says this diagnostic checklist is for doctors across all disciplines to be able to diagnose EDS. And it says the clinical diagnosis of hypermobile EDS needs the simultaneous presence of all criteria 1, 2, and 3. It does not say these are guidelines, follow your clinical judgment. Am I right or am I wrong?
Yeah, they should change that to guidelines. That should be guidelines. But here's the thing. It's fine to sit down and, sit down together, and a lot of
It's
smart people
important.
sat down
Yeah,
together.
it's important.
And I think it was a huge step when they came
Right.
out with this.
Right.
Because before this, it was the Wild West.
Right.
Everybody was using their own criteria.
Mm-hmm.
And unfortunately, it was not made firm. So a few years went by and there was no studies to confirm that this diagnostic criteria was true and correct in every form.
Mm-hmm.
Or, there was, and a lot of the, like I have a not local, but in my region, I have a geneticist who sees a lot of EDS patients, but will not use the 2017 criteria.
Oh, interesting.
He doesn't use it. And a lot of doctors have said, a lot of the geneticists have said that they won't use this criteria. Because, I don't know, I've never asked them why, but I'm assuming it's because it's not, it's too restrictive. It is. And plus, there's like over here, there are 2 points on echocardiogram, mitral valve prolapse or aortic root dilatation. So
Right.
what do you want me to do? Hold off on diagnosing you till you go and get
Right.
an echocardiogram and come back?
Right.
So these are some of the things that need to be, make it a little more looser, not so tight. And also, one of the things that I get some pushback from people who are skeptical about the diagnosis of that the existence of EDS. There are, believe it or not, in this day and age, there are physicians who think EDS doesn't exist.
Mm-hmm.
And there is, because, oh, you didn't get this diagnosis from a geneticist.
Mm-hmm.
The geneticist is going to do the same, is going to look at the same 2000 criteria as I am looking at it or anybody else is looking at it. He's
Right.
not going to do a genetic test because there is no genetic test.
Right.
And then that's my other thing, pet peeve about this whole genetic thing about diagnosing EDS is there are so many other conditions that are hereditary, but we don't send them to the geneticist. For example, migraines. There is a type of migraine called the familial hereditary migraine. We don't send them to a geneticist to diagnose them.
Mm-hmm.
There's a form of high cholesterol that is familial. It's based on the diagnosis. It's based on other things. It's not based on sending the patient to a geneticist and say, hey, does this patient have hypertriglyceridemia?
Right.
So there are many, many conditions. Marfan's, for example, let's take a connective tissue disorder. Marfan's, you don't need to have a geneticist make that diagnosis. If you meet the criteria, you don't need it. So there are many conditions out there. Yes, you can get the geneticist to do a genetic test to make it absolutely sure that this is Marfan's, but you don't have to. And even the published literature on EDS that's out there has said that to diagnose somebody with hEDS, you don't need a geneticist. So there are many conditions that are hereditary that we don't need a geneticist to make that diagnosis.
Mm-hmm.
But yet there are physicians out there will not accept a diagnosis of EDS because it wasn't made by a geneticist.
Mhm.
And then we have geneticists who don't want to accept the 2000 criteria, and they have their own. They're still looking at the Villefranche criteria or whatever Brighton criteria and all that, and they're still
Mhm.
basing it on that. So there's a lot of education to be done out there, and we'll talk about that later on.
Yeah, there's a lot that needs to be done, and you're absolutely right. There are people who try to get in to see a geneticist, and they call the office, and the geneticist office says, "We won't see people who have suspected hypermobile EDS." There's not enough geneticists to go around. I mean, we know that this is a much more common problem than what was originally thought. So, yeah, the geneticists need to be focusing on the more rare things, the more complicated genetic things and things like that. So, and I think the criteria, the 2017 criteria are, like you said, it's a great start. It's a really good, well-intentioned thing. But yes, following it up with studies would be fabulous to see. And I don't know, maybe for the road to 2026, maybe there are studies that are going to be evaluated to see, I know there are some studies that have looked at which of these criteria of feature A of criterion 2, which ones are more common. I know, for example, pyogenic papules was one that was like out of those 12 things, that was one that was more common in the people that had a hypermobile EDS diagnosis relative to some of the other things. So hopefully there's studies like that that are being done that will, really help to decide what the criteria are. Because a lot of people obviously are very upset because they either had a diagnosis and it was taken away, or they thought that they should have a hypermobile EDS diagnosis, but they missed, by 1 point or something, and so the person said, "Nope, I'm gonna diagnose you with HSD." So I and we always say that HSD can be just as serious, if not more so in some cases, than hypermobile EDS, but we know that that's not the reality, right? There's people who, are having the hypermobile EDS versus the HSD label, and they get treated very differently, and people take the hypermobile EDS more seriously.
Yes. So I don't. I think I may have. It's very rarely that I'll diagnose somebody with HSD. I mean, I can count them on my one hand,
Really.
how many people I may have diagnosed with HSD,
Mhm.
because I don't. I don't take this criteria as so strictly and tightly.
Mhm.
For example, if your pinky finger is supposed to go to 90 degrees, right?
Mhm.
And if it goes to, say, 89 degrees or 80 degrees even, does that mean you don't? So I don't go that far.
Mhm.
If your elbow is hyperextensible, and anyone can see it's hyperextensible, but it doesn't meet the exact degrees with a protractor or a goniometer, it doesn't meet that criteria. It doesn't mean I'm not going to diagnose you with EDS.
Right, right.
I take it a little more. I fluff it a little bit. I
Mhm.
take it a little more loosely, because if everything else squeaks, if everything else meets, I'm not going to be hooked on that one little point. If your car looks like a Toyota Corolla, runs like a Toyota Corolla, and it says Toyota but doesn't say Corolla, it's still a Corolla.
Right, right. And I think there's a big difference between a primary care doctor using this criteria and somebody like you who has seen, I don't know how many thousands and thousands of people with EDS that you've seen over the years. It's a lot. So you can pick up on it probably super quickly. Whereas a family practice doctor who wants to learn the criteria and wants to be able to diagnose hypermobile EDS, they've seen a lot of people with hypermobile EDS, but they haven't diagnosed them yet. They've seen them in their clinic, but they didn't necessarily know that that's what was wrong with them. So if they're just starting out, I think it makes more sense for them to be more closely tied to a set of criteria, because for them to use their gestalt is going to be a little bit different, don't you think?
Right, right. Because they don't realize it as that this is a fluffy criteria. It should be fluffed up a little bit, loosened up a little bit. And I agree. And, I had a very interesting discussion with a very famous pediatric cardiologist who's written a lot about POTS. And I said, this criteria for diagnosis of POTS, where your heart rate has to go
Mm,
up by 30 beats per minute, How tight is that criteria? And
Speaking of criteria.
he just broke out, he cracked up laughing. He said, yeah, we have people who have been told that they don't have POTS because their heart rate did not go up to 30, but went up to 29.
Oh my gosh.
I'm like,
Right.
that is exactly true.
Right.
The patient is lightheaded, is fainting all over the place, is having palpitations, has all the symptoms of POTS, but their heart rate did not go up by 30 beats per minute. It just went up by, say, 28 beats per minute.
Right.
And they're like, sorry, you don't have POTS.
Right. Right. Because we human beings pick those numbers, right? We pick the number of 40 if you're 19 or younger and 30 if you're over. So, yeah, we just pick those numbers. We could have picked 25 or 35 or whatever. So, yeah, no, I think that's another great example. So, I appreciate you bringing that up.
That's where experience comes into
Right.
play. If everything else matches and there's one little criteria that doesn't match, okay, fine. The patient has the condition. Our job is to, even if you don't name it, treat the patient.
Mhm. Right.
And that's what they've said in the EDS Society Association and everything else. In the EDS literature, they've mentioned again and again is, if the patient has the symptoms, then treat that,
Right.
whether the patient meets the criteria or not. So if you're having a patient with lightheadedness and palpitations and anxiety and all the other symptoms of POTS and does not quite meet the criteria, go ahead and treat it. You're not going to say, it's not POTS, go home. I don't know what's wrong with you.
Right. Yeah, no, I totally agree. Unfortunately, the latter is what often happens. People go in for an appointment and they say, "Nope, well, you don't have this, you don't." I mean, I don't know that they necessarily are saying you don't have POTS because if they know about POTS, then they probably are gonna say, well, an increase of 28 or 29 or whatever the number might be, if they even did do a tilt table test or Nassau lean test. So they're doing, orthostatic vital signs in their office. I would hope that they are going to take that approach and they're gonna treat the patient. But I hear from, listeners of this podcast all the time that because they don't have these labels, they're being denied treatments. And so that is a huge problem.
That's right.
So we have had such a great conversation. Can you believe it? We've already been talking for about an hour. So we are going to have to defer some of these questions to our next conversation. And as you know, we always end every episode with a hypermobility hack. So you already gave us a hack in part 1, but do you have a hack for part 2 for us?
Hacks come to my mind. They just come into my brain at certain times.
That's fair. I have to tell you, I want to tell you just to buy you a little time because maybe you'll come up with a hack while I'm mentioning this.
If you give me a problem, I might come up with a hack.
Okay, okay, I will think of a problem. But I just have to tell you, people love your analogies. Every time that you've been on the show, I get people saying, first of all, how much they love you, and second of all, how much they love how you explain things, and they love your analogies. So I just had to throw that in there.
I like analogies because medicine is a complex subject.
Mm-hmm.
And you have to think of in terms of how people who are not, who are not physicians and have, even with physicians, I still use analogies.
Mm-hmm.
So when I'm talking to my patients, I'm talking in terms of how we use in our day-to-day lives. And that's how I explain to them.
Mm-hmm.
But if you give me a problem, I might think of some hack.
So I let me give you a problem. What about the person who suspects that they have POTS, they suspect they have hypermobile EDS, and they really don't care about the label, but they do want treatment. So they're going in for an appointment. They're listening to this podcast. They have an appointment next week, and they want to get treatment for their hypermobile EDS. And we know there's no magic pill for hypermobile EDS. There's no magic pill for POTS either, but there are some treatments. What would you tell that person? Do you have a hack for that person who has this upcoming appointment and they're less concerned about the label than they are concerned about getting some treatment that might help their symptoms?
Sure. So the first thing is you go to the local pharmacy or you go to Amazon and buy a blood pressure instrument
Mm.
and check your blood pressure and your heart rate. And of course, you can do that whole tilt tables thing at home. Just lie down and for 15 minutes, get your blood pressure and your heart rate, stand up, take your blood pressure and heart rate, and then again wait for 10 minutes standing, take your heart rate and blood pressure. And if there is an increase in the heart rate, don't worry about the 30 number. If your heart rate increases, your blood pressure is relatively low. It's not high, but it's relatively normal to low. Then just go to salty snacks, take salt, drink electrolyte fluids, sports drinks, not Gatorade, not Propel. Sports drinks, there are lots of them out there, lots of good brands. Liquid IV is a brand. LMNT is becoming really popular among people.
Mm-hmm.
And I think the amount of sodium in that is a little higher. Take that and compression shorts.
Mm-hmm.
Compression shorts. So whether you are going to the cardiologist and getting a diagnosis or not, even if you go to the cardiologist and they don't give you the diagnosis, but you're still very symptomatic with being lightheaded, palpitations, your heart is working really hard, pumping this, and your brain fogged,
Mm-hmm.
then just do this. And 99% of people who actually have POTS love taking salt.
Mm-hmm.
You don't need to have a label for this. You just need to treat it the way. But always get one of those devices like an Apple Watch. I prefer the Apple Watch because it talks to your phone and it warns you if your heart rate is climbing up. And of course, if you fall, it sends a message to your emergency contacts. But you can use any other device like a Samsung device. There are all kinds of devices that measure heart rate, but it should warn you if your heart rate is rising. And if it's rising, then start taking precautionary measures.
Mm-hmm. And I usually tell people when they're doing the home test to just keep cycling the cuff and keep looking at the pulse for that 10-minute period of time and write down all of the numbers. Because what we're looking for is for the pulse for a diagnosis of POTS or to be consistent with a picture of POTS, right, is for the heart rate to come up and stay up, right? So if we have lots of numbers, that's helpful. Lots of sets of vitals. I had a patient once who was seen in their primary care's office, and the primary care doctor did orthostatic vital signs, and they, for whatever reason, had the person standing for 30 minutes, first of all, which is an incredibly long period of time. And not only that, they recorded in their clinic note the baseline blood pressure and pulse, and then the average over the 30 minutes. And I was like, where's the raw data? Yeah.
No, you know what? The best thing is to get one of those smart watches, right? Say, I'm just going to pick one, Apple Watch. You get that, it should synchronize with your phone. Okay. And that's what I do. Even before I do the whole testing, I look into their heart rate trend.
Mm-hmm.
And you can see how the heart rate spikes.
All over the place, yeah.
All over the place. If it's spiking all over the place, you have POTS or orthostatic intolerance.
Mm.
And for those who are interested, there is Dr. Peter Rose, the chief of cardiology at Johns Hopkins, but he's done a lot of work on POTS and orthostatic intolerance. He's the man, and he wrote a little book recently on orthostatic intolerance. It's worth a read. It's a pretty good book.
I just found it. It's called Living Well with Orthostatic Intolerance.
Yeah.
A guide to diagnosis and treatment. So love it. And it's not even that expensive. So there'll be a link to that also in the show notes. So that's a hack on top of a hack.
Yeah. And I wrote to him and I said, oh, so now you're going to be rich making money off this book? And he said, no, it all goes to Johns Hopkins.
Oh.
And I don't think like 7 years on writing it.
Yeah, I think most of these books that people write, yeah, like you said, take a long time to write. And yeah, I doubt that anybody in this space is ever going to get rich on one of their books. So this was such a great and fun conversation. And as I expected, I knew this was going to happen. I have so many questions yet for us to discuss, but that's okay because we are going to have more conversations. And so I want you to save up your questions. I'm going to save up my questions. If you're listening right now, well, of course, you wouldn't hear this if you aren't listening right now. Please submit your questions to bendybodiespodcast.com. We love answering your questions. And so we will definitely get to lots more topics. Dr. Chopra, before you go, can you let people know where they can find you and if you have any special projects or anything that you're working on right now?
Oh, yeah. Sure. Well, I guess you can find me when you Google me, you'll find me. All those negative reviews are not true, okay?
I don't think you have any negative reviews.
Believe it or not, yes.
Yeah.
But you can find me there. The easiest way is to email my office. It's snapa, SNAPA 102 at gmail.com.
Okay.
And that's the projects that we're working on is we wrote a really nice paper that was my pet project. Was we looked at the number of patients with EDS who were being misdiagnosed.
Mm-hmm.
Guess how many people were misdiagnosed with people who had EDS were misdiagnosed.
Boy,
Not just misdiagnosed, not misdiagnosed, misdiagnosed. Like they were given a psychiatric diagnosis.
Mm-hmm, mm-hmm. I read this.
94%.
Yeah, I read that paper. It was really good.
94%. All we did was we asked everybody who came and we asked these 5 questions.
Mm-hmm.
Have you been ever told that this is in your head? It's because of anxiety or it's conversion disorder or Munchausen? And all you had to do say was yes and no. And we looked at the data and we were horrified.
Mm-hmm.
I thought it would be like 60, 70%. It was 94.4%. So these people are not, it wasn't missed. The diagnosis was missed, of course, but they were instead given a wrong diagnosis.
Right.
So we're now writing a paper. I have a really nice medical student, and he's very enthusiastic. Jan Bin Lee is he's become an expert at writing papers. And
that's fantastic.
Yeah, it's nice to have some good help.
Yes, for sure.
And he's so we're writing a paper, the case series on the whole issue of getting CCI from dental extractions. There's another paper that's in process is, do joint stabilizing surgeries help people with EDS or not? And the results are shocking.
Yeah, no, that's a really good one.
That will need a drum roll for me to give you the results.
Yeah. Yeah, we definitely have to talk about that. I know I was very fortunate with my terrible, loosey-goosey, multi-directional instability shoulders that my upper extremity surgeon was like, no, do not ever let somebody try to tighten up those shoulders for you because it's not going to work. So,
not going to work.
Yeah, no. So, yeah, unfortunately, that often does not have a good outcome. We know people don't heal as well, and oftentimes it doesn't address the underlying problem. And then on top of that, if you end up with CCI or something because of an airway mismanagement, oh my gosh, talk about just a just horribly mismanaged case. So, well, those are exciting projects that you're working on. That's great.
Dr. Bluestein, your Bendy Bodies has made an impact in the life of a lot of EDS patients. Sometimes I'll be telling them something and they'll say, oh yeah, I heard that on Bendy Bodies.
Oh.
I'm like, whoa.
That makes me happy.
And I did go back and I looked at some of your of the podcasts that you've had, and you've addressed quite a few difficult topics in EDS. You've done well.
Well, thank you. It's over 150 episodes now, which means that the library is over 150 hours. Yeah, and if they were all like our conversation with Dr. Bolognese, it would be 450 hours. That was a long one.
That is a long one.
That was a long one. So, well, it's been so fun chatting with you as always, and thank you for the kind words. And I look forward to our next conversation.
Thank you. And thank you for having me once again. And it's always a pleasure.
I really loved that conversation with Dr. Chopra, and I'm sure you did too. As I hear from listeners like you all the time, he's so great at explaining things and has such great analogies and has so many years of experience treating people with EDS and comorbidities. So this was such an important conversation. Thank you so much for listening to this week's episode of the Bendy Bodies with the Hypermobility MD podcast. You can help us spread the word about joint hypermobility and related disorders by leaving a review and sharing the podcast. This really helps raise awareness about these complex conditions. If you'd like to meet with me one-on-one, check out the available options on the services page of my website at hypermobilitymd.com. You can also find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, Twitter, or LinkedIn at HypermobilityMD. You can find Human Content, my producing team, at Human Content Pods on TikTok and Instagram. You can find full video episodes up every week on YouTube at Bendy Bodies Podcast. To learn about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, and HIPAA release terms, or to reach out with any questions, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.